afternoon, everybody, and welcome to this very special event of Altogether Fairer, where we're going to launch our Altogether Fairer strategy for Cheshire and Merseyside. My name's Louise Gittins. I'm leader of Cheshire West and Chester Council, and I'm absolutely delighted to be chairing this event here today. A little bit of housekeeping. We have turned off everyone's cameras and muted everybody with their microphones, only because of the large number of people that we've got here today. We've also turned off the chat function, but we will be turning it back on later on in the event in anticipation of the Q&A session. So there are literally hundreds of you in this virtual room today, and it's great to see you all. If you're on social media, please use the hashtag AltogetherFairerCM. We're going to have a break at just after 3 o'clock for 10 minutes, so we can get a break from the screen and get a cup of tea. The event is being recorded and it will be available on the Champs YouTube channel from tomorrow, I hope. So I think what I'm really delighted to see today is the enthusiasm in Cheshire and Merseyside for so many people from such a wide variety of organisations to come and listen to this very special report. We've had nearly 800 people registered. I don't think we've got that amount who've come on, but I'm sure people will join throughout the afternoon. And today is really about a golden opportunity to come together as partners from all these different organisations. But we've all got one shared goal, and that's to tackle inequalities. All of us want local people in Cheshire and Merseyside to live happy, healthy and fulfilled lives. But every place has inequalities and we want to address the gaps. This is more challenging because of COVID. We know that COVID amplified the inequalities that existed before the pandemic. And importantly, no one organisation has got all of the answers or resources, and we can only really improve population health by working together. Every citizen has the right to good health and well-being throughout their whole life. Sincere thanks must go for the support and expertise of the Marmot team, and we'll be hearing from Sir Michael himself as he takes us through the key points of his report. Our ambition is to see real change for local people as a result of this work. Continuing and worsening health and inequalities are not inevitable, and we want to make a difference. In addition to Sir Michael, we'll hear from Ian Ashworth. Ian is the lead Director of Public Health for Population Health in Cheshire and Merseyside, and our DPH in Cheshire West and Chester. And then we'll hear from Graham Irwin, who's the Chief Executive Officer for the Integrated Care System. They will take us through some of the achievements so far in this programme and the priorities for the future. I'm also delighted to tell you that we've got 2 excellent video case studies of fantastic initiatives that have made a difference to local people in Cheshire and Merseyside. Firstly, though, I'd like to introduce my colleague now, Councillor Ian Moncur, who's the Cabinet Member for Health and Wellbeing in Sefton Council, who will give an address on behalf of the Liverpool City region. Over to you, Ian.
Thank you, Louise. And as you said, I'm just absolutely delighted to be attending today on behalf of colleagues from Liverpool City region. I should mention particularly Paul Cummins, my colleague from Sefton, who can't attend today, but does sit on the advisory board for this programme along with Louise. As we know, colleagues, there are long-standing health inequalities that exist between Cheshire and Merseyside and the rest of England, and between places within Cheshire and Merseyside, all of which have undermined the health and well-being of our citizens. Cheshire and Merseyside have higher levels of deprivation than England, with 1/3 of our citizens living in the most deprived 20% of neighbourhoods in England, causing huge implications for their health and well-being. There are also significant health inequalities in life expectancy within Cheshire and Merseyside, with considerable variations between places and, in fact, within places as well. The Cheshire and Merseyside ICS and the Directors of Public Health I've therefore worked in partnership with the Institute of Health Equity to develop this ambitious programme to improve population health, reduce inequalities and build back further from COVID-19. We've worked together as a system to co-produce this programme collaboratively with all partners. 9 place-based workshops have been undertaken with an amazing 371 stakeholders, shaping recommendations and priorities to address inequalities for both the Cheshire and Mersey system and local places. Participants in these workshops included local authorities, the NHS, voluntary community faith sector, public services, housing associations, businesses, schools, colleges and universities, and most importantly of all, citizens themselves. The programme supports whole system transformation in line with the 8 Marmot principles. It's particularly exciting as ours is the first report where the 2 new Marmot priorities have been included, as well as the well-known 6, familiar to all of us, I would think. 2 new principles have been added by the Marmot team, addressing racism and its consequences, and to pursue environmental sustainability and health equity together. We know that more investment is needed and national policy needs to change. There are committed public servants and leaders in our councils and across our public service partners who want to tackle the causes of poor health. Sir Michael has highlighted these in his work, such as children having the best start in life, citizens having access to good work with a fair wage and a safe home to live in. Too many people and places do not have access to the opportunities or resources they need to fully thrive. In 2021, Liverpool City Region Combined Authority was awarded 3-year funding from the Health Foundation to transform the way labour market programmes and economic strategy were delivered within the Liverpool City Region. I'm wholly supportive of programmes like this, as it's so important to ensure people have good employment, which we know will improve their health and well-being. So finally, the Liverpool City Region leaders and Metro Mayor Steve Rotherham really welcome this opportunity to work with the Marmot team and with all the organisations that can have a real impact on the health, well-being and prosperity of the communities that we serve. Thank you very much.
Thank you very much, Ian. So now we're going to have some presentations about tackling health inequalities in Cheshire and Merseyside. So first of all, I'm going to hand over to Ian Ashworth, who I said before is the lead DPH for population health in Cheshire and Merseyside. And then after Ian, Graham Irwin's going to be coming in from the ICS. Thank you, Ian.
Thanks, Louise, and good afternoon, and thank you everyone for joining with us today. If we could just a couple of slides from myself, but I'll move on to the next one for me, please. I'm Ian, Cheshire West and Chester Director of Public Health, but I work really closely with my 8 colleagues right across Cheshire and Merseyside, and clearly health inequalities is a massive priority to us all. On behalf of them, we're really grateful to Sir Michael's team for their expertise and drive in the report and the findings and the work that we've done together so far. But also, we're really grateful to the work from the Healthcare Partnership and Graham's team, who we'll meet shortly, who's been driving a lot of this work from the original inception. You'll see back in 2019 when we came together as a system and wanted to become as a Marmot community. We've had a few challenges in our lives, haven't we, to get through, but we reinvigorated that work last year, and we had that initial report and an update on that with over 300 people tuning into that, and I think that's also reflective of the passion of everybody's involved today as well. If we can just move on to the next slide for us, please. Thank you. So we'll hear today about some of the really tough challenges that we all face, but actually we'll also hear about some of the amazing work our communities and our teams have been doing and how we can learn from each other around that. The approach that we've taken really was driven from our local place-based workshops and our local teams And that's been really important to us all about how we've engaged there. As you'll see on the screen, we held specifically some 9 local workshops with Sir Michael's team, but local leads and stakeholders. The work has been endorsed by every single health and wellbeing board as well. And we produced data packs to help inform those priorities and take account of local differences, because we will all be at different stages within all of this as well. If we move on to the next one for me, please. Okay, thank you. And some of the other things that we've been able to establish include the sub-regional Marmot Advisory Board. On that, we have political representation. We have academia, we have community and voluntary sector on there, we have businesses as well, and our NHS and local authority representation as well, to really steer this work along with Michael's team. Really massive thank you to each and every Marmot community lead who's been coming together as a group to drive this work and make sure that we're engaged locally to hear the different challenges and how we can improve what we do. That all reports through the feedback into the Healthcare Partnership Population Health Board, which I have the privilege of chairing as well. We managed to produce an interim report that was well shared and highlighted some of the key findings later last year. And obviously today is the final report that's come through. One of the main things that we were really keen to do is establish some set of agreed indicators to measure the change and measure the scale of how we need to progress against the priorities laid out in the report that you'll hear today. They'll get combined into what we call a combined intelligent population health action, sometimes abbreviated as SIP for dashboard, because it's really important that we measure progress on that. You'll also see from there the work we're doing with many of our NHS trusts, but also different local authority approaches around anchor institutions, social value work as well as on that. So if we just move on to the final slide from me. We are on a journey to this together, and I think one of the things we try to bring together today is also a new brand and our vision for that, in order for us to be working as one for a fairer, healthier Cheshire and Merseyside. That's the main key elements from myself, and really great that Graham's able to join us now to take us through his section.
Ian, thank you very much to everybody else. Thank you for attending this afternoon. It's an absolute privilege and honour for me to have been appointed as the Chief Executive for the integrated care system. Now, I thought it'd be worth just starting by setting a little bit of context. So you'll hear some of these phrases used interchangeably, but the Integrated Care Board is the statutory NHS body responsible for planning, commissioning and the oversight of all NHS services within Cheshire and Merseyside. The ICP, the Integrated Care Partnership, known as the Cheshire and Merseyside Health and Care Partnership, will become a statutory partnership between the NHS and the 9 local authorities that make up Cheshire and Merseyside. And this is where we will oversee the tackling of health inequalities and the implementing of the recommendations from the Marmot report. Now, people will have heard me talk in a number of forums already where I have described my 4 top priorities. And I'm not going to go into any detail today, but I'm just going to remind people what they are. So the first is that we keep delivering today, and we deliver well on people who need our services right now. Secondly, that we recover really effectively from the pandemic. And in a couple of minutes, I'm going to give you an example of that. Thirdly, that we are able to build the new systems that promote collaboration and integration. And fourthly, and in some regards, I consider this to be our big prize for managing to do the first 3 well, that we are able to tackle inequalities and take action on the wider determinants of health. If we can move on to my next slide, please. Now, I fully endorse and support the report that we are receiving today. In particularly, the fact that we have got to take action on education, employment, addressing poverty, good quality housing, and in particular inclusivity. But there are lots of other people who are going to talk about those issues as part of this call. So I'm just going to talk about some of the things that the NHS is uniquely placed to do and will do as part of its contribution as we go on this journey together. You've seen on the slide that I've talked here about avoidable mortality, premature deaths, and in particular the gap in life expectancy that exists not only between our most affluent parts of our patch and the poorest parts of our patch, but actually it exists between Cheshire and Merseyside and the rest of England. So let me just give you 2 or 3 examples of what I'm talking about. When I talk about recovering from the pandemic, and part of this might have something to do with the system of measurement that we use, but during the pandemic, the number of patients with high blood pressure who had been diagnosed and had their high blood pressure under control fell from 70% to 40%. And it is only as we recover the services that are in place through the pandemic will that actually help us start to once again see the prevention of stroke. Now, another thing we're doing is through a program called Community Diagnostics, which is a bit of a misnomer, because this is really about getting diagnostics that were hitherto undertaken in hospital, moved out into more accessible community settings. We will deliver by the end of 23 100,000 additional diagnostics to the people of Cheshire and Merseyside. Now, why is that important? That's important because the earlier detection of disease is the thing that will help us, A, by detecting earlier, get better outcomes, but B, get these diseases under treatment and into management. And then more than that, we need to have an underpinning digital transformation program that will start to use technology. So again, once again, in this area of blood pressure and stroke, to see us deliver at scale a technologically driven blood pressure at home service that will help our population take responsibility for managing their own health and start to see our premature mortality rates fall. Can we move on to my next and hopefully last slide, please? I'm not going to talk about all 6 things on this slide, but I just want to highlight 2 or 3 to you. The NHS will commit to these things. Now, the NHS is required by March 23 to publish a very clear strategy for integrated care. And I'm committing now, and all of my colleagues are committed, we will fully incorporate the Marmot recommendations into our 5-year strategy that we will be publishing at both Cheshire and Merseyside and place level. Secondly, the NHS will be an exemplar, and I expect partners to hold us to account for this, but we will be an exemplar in being anchor and social value organisations, and we will be an exemplar in fairer employment and creating opportunities as people come through their careers and looking at careers in the NHS. And then finally, I commit to the better use of data. Now, we have some fantastic systems that enable us to understand our population, understand our population's health, but we don't make the use of those that we possibly could. So I fully endorse the continued development that Ian has already referred to of the CIPHER programme. And what we have to think about is this is about the risk stratification of our population and working out the actions that we can take that will make a real difference. So thank you for inviting me along today. thank everybody for the work that they have done to get us to this point, but we really do need to endorse this now as our kind of call to arms and our movement for change, so that we truly make a difference to the things that we can influence. Thank you. Back to you, Louise.
Thank you, Graham, and I love that call for arms, and I hope everybody who's watching this is going to be fully behind as we go forward. We are going to show a couple of videos now, so we're going to take the slide down and change over. The first room is the first video is about the life rooms in Liverpool and Sefton, and the second one is from Cheshire West about our Poverty Truth Commission. So hopefully our techie people are going to get that up and running, and here we go.
My name's Amy McMeekin. I am service lead for the life rooms across Liverpool and Sefton. It's open to everyone. It's a health and wellbeing service focused around reducing health inequalities and barriers to access, particularly around the social determinants of health.
My name is Andy Litchfield, and my job role at the Life Rooms is community inclusion lead, identifying what the social needs are in that area, whether that's our pathways service for social prescribing, or whether that's our learning offer through the Life Rooms as well. It's my job to see what the needs are and then help the support of mobilisation of services.
So my name's Sean Masterson. I started coming here, it was about 2018, I was about 28. I was a carer for my granddad. I was looking after him for about 10 years. And then when he passed away, my depression got really bad. I was contemplating suicide a lot, and I just basically didn't have anything to live for anymore, really. That was what it was always in the back of my mind. I just thought that's my life finished now. That's all it's leading up to be.
I think the unique thing about the service is the fact that anyone can access it whenever they want, and they can access it for an hour, or they can come back every week for the rest of their life.
The first time I come in and spoke to Wayne, he told me about the recovery college. I looked at the timetable and I was like, this is really good. Like, I can see myself doing some of this stuff. So I put myself down for the anxiety courses, understanding it, managing it. Same with depression, understanding depression, managing depression.
We do try and promote transition and moving, not a dependency on services, but at the same time, if that's what someone needs and that's, that is their potential, then absolutely we'll support that.
Maybe like a sort of state of despair, they're distressed, worried, anxious, sad. Getting them from that point, empowering them, and then seeing that kind of smile on their face and seeing that change from when they come in through our doors and then once they're leaving. There's no better feeling than that, I think, just seeing that change and that we've been able to make that difference.
I think I wouldn't be in if it wasn't for Life Rooms. It's dramatic, but it's true. If I didn't have here, I don't know what I would have done. Probably like drugs or alcohol or something. But having the Life Rooms here and what it did for me changed my life completely.
We've just consulted on our new strategy called the Fair Futures. We also have Community Inspirers, so we will be working with individuals of lived experiences of living in poverty.
It's not just about us as a council, it's really about all of the public sector, but also the private sector as well, and businesses. So it's the scale of the challenge that we face.
It was the commitment of the council, our leader, and some councillors within Cheshire West and Chester. I think they obviously wanted to amplify those voices and really hear those experiences of individuals who've experienced what poverty is like.
When I first went to a food bank, like many people, I felt very shamed. I realised, Susan, you are going to have to ask for help. I went to one in my local area. I wasn't very much welcomed, and you can't just turn up. And then I just felt even worse.
And poverty in the borough to me looks like people choosing between heating and eating and making really difficult decisions and being in survival mode, living day to day.
We started to run workshops with Susan and others to talk about actually what is it that you really need at this point of crisis, at this point of needing help, as Susan said. What does that look like, and what would ultimately help make you feel better?
I think a lot of our inspirers, when we speak to them, how we try and kind of look at it as if they were young now, with what we would be implementing, would their lives be the same, or would we be able to make that change for them now based on all of the things that we're going to be doing, and then hopefully their lives will be different going forward.
I absolutely really feel as though it's made a difference, and equally for me, you know, it's made me, like I say, grow in my confidence again and build my life up, come on leaps and bounds. And I feel that also with the other community inspirers that I work with, I've seen the differences in them.
On our first Poverty Truth Commission, we had our inspirers and they were buddied up, someone from the private public sector who worked with them. The inspirer that I worked with, to start off with, she was lacking in confidence. She wasn't clear about where she was going in her life, but now she sits on a national forum, the National Poverty Truth Commission, and how that has helped them in terms of the passion and drive to actually work with us on finding a solution has been inspiring for me.
So 2 great examples there of inspirational things that are going on in Cheshire Merseyside. Okay, so thank you for watching so far. We're going to have a 10-minute screen break now. We are slightly a few minutes behind, so I'm suggesting if we restart at 3:10. So go and get yourself a cuppa, and I'll see you all in a bit. So we're going to start our second part in about a minute. I hope you all had a good break. It seemed like the longest 10 minutes ever to me, but welcome back everybody. I mentioned before that the chat function is turned off. We are going to turn it on again about 5 minutes before the end of Sir Michael's introduction and speech this afternoon. So if you want to start putting your questions in, that would be really good, and then we'll have approximately half an hour of Q&A time. So please get all those questions in when you see that the chat function's live again. So this is the main event of this afternoon. I'm absolutely delighted to have Professor Sir Michael Marmot with us today, and he's going to take us through the Cheshire Merseyside Marmot Strategy Report. So, Michael, over to you.
Thank you. I said to you at the beginning of the afternoon that this is an exciting day. It's a particularly exciting day because a question that I've been asked a great deal over the last while is, aren't you frustrated? In 2010, you set out recommendations for government at how to reduce inequalities. In 2020, you produced a report saying pretty well all your recommendations were ignored and health inequalities got worse. Yeah, that's not terribly encouraging. But what is encouraging is the commitment at local level. Working with you in Cheshire and Merseyside is what makes me enthusiastic. It's my evidence-based enthusiasm that comes from this local work. And in a way, what we're seeking to address with you in Cheshire and Merseyside is whatever is going on nationally, can local action make a difference to people's lives and thereby improve health and, crucially, equity of health and well-being? Next, please. We had 6 principles in our 2010 review and 2020 review. We've added 2 because of events. The 6 were give every child the best start in life, education and lifelong learning, fair employment and good work for all, a healthy standard of living for all, healthy and sustainable places and communities, and taking a social determinants approach to prevention. The 2 we've added, particularly in light of COVID, was tackle racism, discrimination and their outcomes, and given everything that's going on, pursue environmental sustainability and health equity together. And as already been said this afternoon, it's really in Cheshire and Merseyside that we're pursuing all 8 for the first time. Next, please. So the national context, as I said, in our 2020 report, the 10 years on report, we documented the fact that life expectancy, which had been increasing about 1 year every 4 years, that rate of increase slowed dramatically. In 2010, there's a break in the curve. Something happened. And without attributing cause and effect too precisely, it would be odd not to ask if it were related to what the government of the day instituted in 2010, indeed to policies of austerity and cutting back. And then to 2020, life expectancy dropped further, a huge COVID impact. Next, please. More recent publication from ONS looking at the 3 years, 2018 to 20, compared with the previous 3 years, showed a decline in life expectancy for the 4 poorest deciles. And in fact, for men, it didn't improve at all across the social gradient. Now, up to 2020, we had shown a decline in life expectancy for women in the poorest decile. But now, with the effect of the pandemic, compared with the three previous years, we've got a decline in the 4 poorest deciles. This is incredible. We expect health to improve all the time, and it's getting worse. Partly pandemic, but not only pandemic. It was getting worse for the poorest people before the pandemic. Next, please. And healthy life expectancy shows a steeper gradient. Not only do people in the most deprived area have shorter lives, but they spend more of those shorter lives in ill health. Women living in the most deprived areas of England are expected to live 1/3 of their lives in poor general health. This is the national picture. Next. The Food Foundation has been brilliant in drawing our attention to food insecurity. Household food insecurity levels increased by 60% since the beginning of the pandemic. This is October 2021 to April 2022. Next slide, please. And if we look at food insecurity more recently, this 3 elements had a smaller meal than you would have wanted to sacrifice to appease your hunger, skip meals, being hungry but not eaten, or not eaten for a whole day. There was a more than 50% rise in food insecurity between January and April. And in April 2022, 1 in 7 households suffered food insecurity. Good heavens, 7.3 million adults. Next, please. And families with children, it's 20%, 1 in 5 of households with children experience food insecurity. This is the national picture. So when I said things were not going well up till February 2020, this is where we are in April 2022. 1 in 5 households with children have suffered food insecurity in the past 6 months. Next, please. Meanwhile, food and energy billionaires are $453 billion richer than 2 years ago, finds Oxfam. Bully for them. Next, please. We pointed out in the 2020 report that the government was quite successful in meeting its objective, which was to reduce public expenditure, to roll back the state. In 2009-10, 42% of GDP was public sector expenditure. By the end of the decade, that 42% had become 35%. And it is likely that that played a role in the slowdown in improvement in life expectancy and the increase in inequalities. Next, please. Next. The government produced a levelling up white paper. I reviewed it, wrote a commentary for the BMJ, and I applauded the analysis for objectives, 12 missions, terrific. But it's been pointed out that the Levelling Up Fund allocation for 2021 was £32 per person in the North. The drop in annual council service spending over the period 2010 to 2020 was £413 per person in the North. So you take £400 away and give £30 back, and you say levelling up. What it means is that we cannot depend on central government to do what's needed. Next slide, please. We've also been working with industry. Legal and General, an insurance company and financial services industry, approached us and asked, what is it we could do to improve health and health equity? So we produced a report, The Business of Health Equity, the Marmot Review for Industry. Next, please. And we said there are 3 domains where industry can make a difference. And we hope that we can work locally in Cheshire and Merseyside as well as elsewhere. The first is providing good quality work, pay. Every employer should pay the real living wage. What a radical idea. People in work should earn enough to lead a healthy life. And of course, the conditions of work are vital. The second are goods and services, what the industry does. Is it producing goods and services that are damaging people's health? What about goods and services that improve health? And the third is thinking of industry as an anchor institution, as has already been referred to in thinking about healthcare, having a positive impact on the community, on the environment, procurement, chains, and the like. And we're encouraged that we want to be working with industry as well as with local government, as well as with ICSs and the voluntary and community sector in different areas of the country. Next, please. So that leads us to Cheshire and Merseyside. The Levelling Up strategy has priority categories. So Knowsley, Liverpool, St Helens and Wirral in the first category, the percent of the population income deprived, 25, 23.5, 18, 17, and ranking of income deprivation in England's 316 local authorities. Knowsley is the second highest deprivation, Liverpool the fourth. One of the issues, though, is Cheshire West level 2, Halton. Why is it in level 2, not in level 1? Sefton. Why is Sefton in level 3, not in level 1, given the percent of the population that's income deprived? Next slide, please. And in the early allocations, 8 councils from among the poorest 5th in England are set to receive less than £10 a head in Levelling Up funding. Knowsley, nothing. While some areas within the most affluent 5th are set to receive many times that amount for every person. I haven't drawn attention, and far be it from me to draw attention, to the ones that have missed out tend to be Labour, and the ones that did very well tend to be Conservative. I would hope that that wasn't driving the levelling up mission. Next slide, please. I pointed out that the allocation from IPPR, the allocation in the North local government had reduced drastically over the decade. Knowsley, £700 per person annual spend. Liverpool, nearly £700 reduction in the annual spend. This was the English average, £330. And all of these, 6 of the 9 local authorities in Cheshire and Merseyside had bigger reductions than the national average reduction, which itself was huge. So it's making things much more difficult in Cheshire and Merseyside. Next slide, please. And that relates to life expectancy. If we look at the index of multiple deprivation, high deprivation, low male and low female life expectancy in Liverpool, Knowsley, Halton, St Helens, and then we get to Cheshire West and Cheshire East, less deprivation, longer life expectancy. It is a remarkable gradient, even among the 9 local authorities of Cheshire and Merseyside. Next, please. And when we look at COVID mortality, this is the male average. Northwest, higher than the average for the country. That's the female average. Northwest, higher than the female average for the country. And in 7 of the 9 local authorities, the COVID mortality is higher than the national average for men, and there we are, in most, higher than the national average for women. Next slide, please. People vaccinated for COVID-19 having at least 1 or at least 2 doses, white British, Asian or Asian British, something of a deficit, not huge, but still more than we would want. Asian or Asian British, any other Asian background, Black or Black British, and so on. There are ethnic differences in uptake of vaccination. Next slide, please. And socioeconomic differences. Most deprived, at least 1 dose, at least 2 doses, and at least 3 doses. Everything we look at is a gradient. The less the deprivation, the higher the vaccination uptake. Next, please. And still in Cheshire and Merseyside, children achieving a good level of development at the end of reception. All over the country, children eligible for free school meals have a lower proportion with a good level of development at age 5 than the average. And this is the average for England for free school meals pupils. And we can see in 8 of the 9 local authorities in Cheshire and Merseyside, the poor kids are doing worse than the national average. And it's not great for the average children either compared with the national average. Next slide, please. Average attainment scores, free school meals children doing worse than the national average, and just about bumping along at average or lower than average for the average child. Next. Number of jobs per resident. Wirral, St Helens, Sefton, all lower than average. It's harder to get employment in these local authorities than the average for England. Next, please. Average weekly earnings. That's the national figure. And in 7 of the 9 local authorities, it's less than the average. Only Cheshire West and Chester and Warrington are doing better than the national average. Next, please. Earning below the real living wage. Men, nationally, it's about 14% of people earning below the real living wage. And the figures for most of the local authorities for men aren't so bad compared with the national average. Wirral's a good deal worse. Women, well, not great. The national average for women earning below the real living wage is higher than for men, and several of our local authorities are doing worse than the national average. Next slide, please. Children living in absolute poverty households, higher than the national average. And the national average, of course, has been going up. Next slide, please. And children living in relative poverty. The benchmark is a difference, the benchmark is different between the absolute and relative. But again, it's high in at least 4 or 5 of our communities. Next. Fuel poverty. This was 2019. Way out of date. Fuel poverty is, of course, soaring and will get worse. Next slide, please. Number of food parcels delivered by the Trussell Trust at Cheshire and Merseyside, 2019-20, 2020-21. It's actually gone down a little bit, but it's still huge. Next. I've given you the national picture, which is pretty depressing. I've shown a snapshot of what's going on within Cheshire and Merseyside. That's the bad bit. Now comes the good bit. Examples of good things that are already happening on which we seek to build with our recommendations, how to take this forward. Regeneration, the Strand shopping centre to be reimagined as the beating heart of Bootle in a new vision set out by the council. Regeneration. Next, please. Advice on prescription. Why not everywhere in Cheshire and Merseyside? Liverpool's CCG and Citizens Advice partnering. Embedding social welfare advice services in primary care. There is a national movement for social prescribing. It is alive and well in Cheshire and Merseyside, and we'd like to see it more generalised. It's recognised nationally as good practice, but not replicated locally. We'd like to see more of it, actually recognising the social determinants of health, and healthcare people on the front line can do something about it. Next. This is a bit nerdy, but don't forget the importance of measurement. So we know the nature of the problem, we know what's going on, and we can monitor progress. Primary care, social care, mental health data, secondary care data. Oops, go back, please. Advice on prescriptions. And the data have got to come from all these different sources. So collecting those data and linking them up is vitally important. Next. Next, please. I've talked about food insecurity. What I haven't mentioned in an opinion piece I wrote a few weeks ago, I said that dignity is fundamental to who we are and how we're seen in society. It is undignified to have resort to food banks to feed your children, undignified to wear 2 overcoats indoors to keep warm, undignified to seek relief from your landlord so you won't be evicted through failure to pay the rent, undignified to deny children a birthday party. So the question is, can we feed people with dignity if they can't afford to eat? And the bread and butter thing is indeed trying to feed people with dignity, make a difference. It's fundamental. You think, what do we want from society? At the minimum, we'd like people to be able to eat, to have shelter, and to be warm, and to be able to do those things with dignity. Next. And that relates to the cost of living. I said I wrote an opinion piece, and I said what's about to happen in the UK with the cost of living crisis is unprecedented. It will be a humanitarian calamity in the 5th richest country in the world. Knowsley, Better Together, Liverpool Citizens Support Scheme, emergency support for people who cannot make ends meet. It's not terribly helpful to tell people who are living in poverty that it's their own fault and they're ignorant and they don't know how to cook or budget or look after themselves. Not only is it not helpful, it's not accurate. And the question is, can local action make a difference? And what you're showing us in Cheshire and Merseyside is local action can indeed make a difference. Next slide. And we've got a set of beacon indicators. I said it's important to know what's going on. And we have something similar in Greater Manchester. And this was developed in consultation with hundreds of people in Cheshire and Merseyside. Next slide, please. And I just pulled out 3 here because I think what's going on in Cheshire and Merseyside has the potential to show the way for other parts of the country. So look at the percent of employees who are local, employed on contract for 1 year or the whole duration of the contract, whichever is shorter. In NHS local government. In other words, is there success in employing local people? The percent of employees who are from ethnic minority background and particular band levels. The percent spent in local supply chain through contracts. We think these are all good things for local action. And we want to be monitoring those. And if Cheshire and Merseyside does it, it can show the way to every other region in the country of what's needed. Next slide, please. So I finish in a way where we started. Our 8 principles: give every child the best start in life, education and lifelong learning, fair employment and good work for all. This could not be more timely. As we speak, day after day, the issue of a healthy standard of living for all is absolutely vital. Healthy and sustainable places and communities, and taking a social determinants approach to prevention. And the 2 that we've added, tackle racism, discrimination and their outcomes, and pursue environmental sustainability and health equity together. Next. I'm often asked, what's the one thing you would recommend? I've just laid out 8 and I get asked, what's the one? Well, the one is put equity of health and well-being at the heart of all policies. national, regional, local, government, non-government. Put equity of health and well-being at the heart of all policies. Next. And I would like to think our report, Altogether Fairer, Health Equity and the Social Determinants of Health in Cheshire and Merseyside, will be not just an important local and regional contribution, but will be an important contribution to the national picture to build back fairer. Thank you.
Thank you, Sir Michael. That was fantastic. You're getting lots of claps there in the reaction, which is absolutely brilliant, and hearts and everything. Some real sombering figures there, and it sort of demonstrates the challenge that we've got going forward. In case anybody's sort of wondering, well, where's the report? It's actually going to be showcased on Newsnight tonight. So once that's been aired, it will come out, and the clapping continues. And I'd just like to say thank you on behalf of Cheshire and Merseyside for all the work of you and your team in terms of how you've supported us to come to this point where we can now go forward for a better future. So thank you, Michael. I noticed some people have got their hands up. We're not going to be able to do it like that. So if you want to put your question in the chat, that would be great. And could I ask all the contributors so far to turn on their cameras? So Ian and Graham, because yes, both Ians, we're going to be asking questions of all of you. So please, if you could put your questions into the chat, and I'm going to ask a question just to get going. So Michael's already answered what is the one thing that you would take from this. So I'm going to ask each of you what would be your one priority based on Ian Ashworth as Director of Public Health, Graham as Chair of the ICS, and Ian as a political lead. So Ian Ashworth first, and then I'll come to some of the questions in the chat.
So, to be fair, I've asked Michael's team that question about priorities, and I was quite rightly told back before, and not just one, all 8, and not to lose focus on that. So I think the key thing for me is we take back all of those priorities into our local plans and how we are delivering on them. One of the key things that came out today, I think, was just learning from some of the social prescribing and the welfare advice and support for me, and how we got some wonderful social prescribers out there and wonderful community sectors. So we need to look at that a little bit more and make sure people can get the support and help they need when they can.
Thanks, Ian. Graham?
Some of this is intergenerational. You know, investments that we make now will pay dividends for our children, our children's children, and so on and so forth. I want to make it my priority that we also don't lose sight of the short-term things, and we really go for a reduction in the preventable mortality that comes around coronary heart disease. So I know that's a slight deviation for the wider long-term piece, but all of this will contribute to people in our communities living longer and enjoying better health in those years that they live longer for.
Thanks, Graham. And Ian Moncur, finally from you. You're on mute.
Do apologise for that. I think for those of us in local authorities, I think the key thing coming out of that is actually making those translating those things into action at a local level. And we've seen some great examples today, and it's just building on those local examples and how we share those, combined with, I think, ourselves in local authorities as local politicians do have that responsibility and opportunity to actually continue to pressure government on the issues that we've seen highlighted in Michael's slides.
I'd agree with that, Ian, and I think if I could just sort of come in with my view, I think in local government we need to think about all the decisions we make and how they are going to contribute towards this journey that we're now on. So that sort of health equity in all policy, I think is really important. But yes, we need to lobby government really quite strongly. Okay, so I'm going to start with some of the questions that are coming up in the Q&A in the chat. So there's one for David O'Hagan. Michael, I'm going to come to you first with this. It says, first of all, thanks for an excellent presentation. How do we reduce social stigma, the exposure to risks, the effect of harms and the consequences of harms by policy interventions, by health and social integration? So I think what David's trying to say from that is, how do we sort of look at health and social care integration and balance all those risks that could come as a unintended consequence, I think.
My reaction to that is the effect on me of engaging with representatives from local communities. I think it just changes everything. If you come with a particular view about stigma, about labels, and then you actually engage with people from local communities, you come away with a very different view. And the words that get used often, but I think we need, as Ian said, to translate words into action, is partnership, is working with local communities. Then issues of stigma don't really arise. It's really quite different. How do we, those of us who are responsible for delivering services, how do we do it in a way that is responsive to and meets the needs expressed by local communities?
Anybody else want to, Ian, Graham or Ian, contribute to that one, or should we move on to the next question?
I think, Louise, there is something that every community will always, in the long run, be able to consume more resources than any government will be able to spend. And that makes people really, really busy, and it makes people feel that they're always running to catch up. It's our job to create the space for people to be able to redesign and transform services, and you cannot redesign and transform services without listening to the patient, the citizens, the service users. And too often we get into a space where people are just too busy to do that, and it's our job to make sure we create that space and we actually really listen to people, because a number of our services, well intended, and a phrase I quite like is, quite often we hit the target and we miss the point. And I think, I would say 450 people on this call right now, a number of those people are not from the NHS or from local governments. You need to be calling it out. You need to be telling us when we get it wrong. We are here. We want to be held to account to make a difference for the people that we serve.
Thank you. Ian or Ian, either of you want to come back on that? Or should I move to the next question?
Louise, I think that just sort of related to the couple of things raised. I think the really important thing to me is about that partnership ethos that we've got, and we're driving that, and that's reflected on who's joined the call today. I think one of the challenges we've had is making sure we don't stigmatise communities or areas about the challenges that they face, and acknowledge what can be done in a positive way. I think one of the things we've heard about is working people with lived experience and making sure that they shape the work that we're doing and how we can improve things even more so. So that's just my kind of view on that partnership approach, really.
Other Ian?
Thanks, Louisa. And forgive me, this is a slight liberty, but I don't know how to other people, but I've never been on a Teams call where there's nearly 500 people on, and certainly on the chat facility, and it's absolutely, you know, the stuff that's coming on there is absolutely amazing, and it's quite difficult to keep a grasp of. But I think somehow one of the things from today, I think we hopefully can just grasp some of the points that are being made there, in terms of trying to exactly the point that I think Graham and Ian have just made. Lots of people on this from outside local authorities, the NHS, etc., with lots of good ideas, lots of good questions, and trying to kind of capture that and make those connections is probably going to be one of the most helpful things that we can do as a result of that. I think there is some of this. I think possibly that there is something of where the situation we're in. There's lots of opportunities. I think one of our big challenges is about capacity. So we do have lots of good ideas, and one of Michael's slides was referred to a project in Sefton about the councillor involved with the Strand. We are moving forward on that. One of the challenges we have is within the resources, just the capacity to develop those ideas. And I saw in the chat somebody a couple of minutes ago, a local organisation in Netherley with a bike facility, and just asking simple questions about who they could link up with and how they could be helped. And it's that sort of those are exactly the sort of points that we just need to be trying to make those connections and get that mutual support going to actually make that real difference at local levels. That stuff is within our control, but we just need to make those connections.
That's a really good point. I picked up on that. People saying, can I email you and get in touch and all of those things. And it's making those links, isn't it, to make that difference. So the next question I've got is about how do you think we can shift the focus away from health behavioural change in the poorest and the least powerful individuals to behaviour change in those with the power to make a long-term difference? So rather than blaming people in poverty, who are helpless, really, they can't make those big changes needed. How do you think we can shift the emphasis? Michael, I'll start with you first.
Well, if the people whose attitude we're trying to change are impervious either to evidence or reason, then I don't know how we can shift. But the way I try to do it is show the evidence. So if somebody says, for example, a conversation I had quite recently with our work with business, the head of a large corporation said that individuals are irresponsible and people like me are actually taking away responsibility by saying that it's somehow social structural. And I said, well, the evidence is that for people in the bottom 10% of household income, for them to follow the healthy eating advice, they would have to spend 74% of their income on food. They're not being irresponsible, they're being poor. And given that more than half of the people in poverty live in households where at least one adult is working, responsible here, it's the employers who aren't paying a living wage. I said, if people in the top decile of household income, who only need to spend about 5% of their income on healthy eating, choose to feed their children fizzy, sugary drinks, those rich people are being very irresponsible. And you're right to criticize them. but don't criticize the people who are in poverty. So that's what the evidence shows. There's also evidence that people in poverty are probably as knowledgeable, if not more so, about cooking, about budgeting. So the evidence, if evidence and reason make a difference, the evidence shows that that attitude, that it's all about healthy behaviors, and if people choose to behave unhealthily, they've got no one to blame themselves. That attitude is contradicted by the evidence. But I'll say it a third time. If evidence and reason doesn't change somebody's viewpoint, then I don't know what does. Maybe winning the World Cup or something, I don't know, but it's illogical. I stick with the evidence and reason.
Ian Ashworth, anything to add to that?
Touching on listening, at that, you know, and understanding what we had an example before about the challenges just going to a food bank that would, you know, prevent behaviour change happening and feeling the confidence to be able to do that and seek that support. I was just making a couple of notes. One of the things that we have to look at is the standards of our housing and the standards of safe and well, quality workplaces as well. You know, making sure people are paid the right amount of money to be going to work and can do that rather than it being not a choice to. That includes travel. So the cost of travel and the frequency of being able to get to where you need to get to. So adopting that equitable approach of how we offer services when people may need them closer to in their community at times that they can access them, and the quality of those services as well. So, you know, the NHS are under massive pressure around the recovery of services, but we need to make sure those quality of services are in the right place, the areas of need that we mentioned before. But also we've got an opportunity of how our communities are shaped to make sure people do get access to safe communities, green open spaces, encouraged to maximise their time in those areas as well. So I think there's some of the things that we can have an opportunity to build upon, really.
Thank you, Graham.
It's an absolute honour and privilege to do the jobs that many of us who are on this call today do. We have to remember that with that honour and privilege comes a requirement for us to advocate really clearly for those people within our communities who are less able to advocate for themselves. What we also have to do is we have to recognise our own limitations in our ability. And that's why having a really clear strategy for the way that we work with the voluntary, community and faith sectors, who can actually reach out into these communities, sometimes have so much more credibility than us, the paid professionals, and use those routes to make sure that we listen and that we understand and that we respond. So I think the first thing is we have to take our responsibility really, really seriously. We have to do that with humility, and we have to do that in service of our communities.
Thank you, Graham. Ian Moncur, do you want to add anything to that from a political perspective, politician's perspective?
Yes, thank you. I think the point about this is that I think as local politicians we must continue to push the case with national government, because some of the things, whilst we quite rightly talked about what we can do at a local level, whether that be Cheshire and Merseyside or more locally within our local authority areas, nevertheless there is and absolutely requires national policy change to make this happen. And I think the what we've seen today, particularly any number of the slides that Michael showed in his presentation, just highlight actually why, some of the main reasons why we are in the situation that we are and things that need to change. So we would need to keep pushing them. I think it's interesting that, you know, obviously far from being an advocate for this current government, but it's interesting that pressure sometimes does have some sort of effect, in that the announcements we've seen today on the government announcements on the fuel sort of changes that they've made today. So I think the point is there, pressure can have some effect, perhaps not the full effect many of us would want to see, but we've just got to keep pushing and pushing to make that change happen, and use an evidence-based argument to actually give that sort of weight to our elbow of the particular argument.
Thank you, Ian. Some interesting answers there. There's quite a lot of comments about co-production and co-design of the way that we do things, and involvement of the community and voluntary sector. Has anybody got anything they'd like to sort of comment on and add of how we can ensure that all of that happens? Because there is a worry this will be a top-down approach. So, Michael.
Well, I've wrestled with this a great deal. I think what makes me uncomfortable is that, in a way, I'm an outside expert. And I can give you all the reasons why you should disparage outside experts and distrust them. So I've earned your distrust a priori for being an outside expert, because we know a lot. I've been reviewing these area I've been doing research on it for more than 40 years, and reviewing the evidence on what we can do for the last 15 or 20 years. And we don't want to throw that knowledge out the window. So the real challenge is how you work with local communities to say, we've got a handle on what the key drivers are here, of what needs to change. But for us to come in and say, you've got to do X, Y, and Z is wrong, it's probably immoral, and it's likely to be ineffective. So the challenge is to bring the knowledge that comes from outside, from all around the world, and work with local people to make that knowledge comprehensible, meaningful, engaging in the right way to act on it, but not to throw it out. So there's some asymmetries built into all this. A lot of the sort of technical scientific knowledge comes from outside. The lived experience comes from inside. And we've somehow got to put those two together. That's not straightforward. People talk about co-production, partnership, shared working, all of those things. It's not straightforward. It's a major challenge, but that's the one we have to solve. If we only have the one and not the other, whichever one it is, then it's deficient.
Thank you. I'll mix up the order a little bit. So Graham, do you want to come in next?
No, I've got nothing to add on that, Louise. Go carry on with the other colleagues.
Ian Moncur, anything to add to Michael?
No, I don't think so. No, trying to get through some more questions. Yeah.
Okay, Ian Ashworth.
I will just add that the community sector has played a vital part in all the work to date, which we know of, and there's many on you can see in the chat as well. But they are involved as part of all this journey, and have to be as well. We have local areas have compact agreements, but the investment in there needs to be right as well to assist us, doesn't it? So more of an opportunity to say thank you to them, really.
Thank you. So quite a thorny question coming up next. So someone says we've got the language right, but have we got the how and the maturity required to engender real system change? So the question is, how do we effectively network all the relevant parties, share power and flow the funding to create an imperative around health rather than the treatment of illness? So in other words, how do we use the money within the system to go right back down to keeping people healthy and happy, rather than just treating illness, and making sure that that money flows around the system. So Graham, I'm going to come into you first for that one.
Okay, thank you very much, Louise. You know, that's fundamentally a tough question, isn't it? Now, one of the things that we often say to people is people often concentrate on the new little bits of money that at any point in time the government give us, because all of our services are funded by the government. And I'll often say to people, we can do far more by looking at the whole and changing and transforming the whole. So this is about our ability to really look at everything we do, stop doing some of the ineffective things that are happening today to enable us to work differently. Now, the reality is the NHS and our partners in local government will have to find some money to almost create the seeds of change. But we've proven that we can do that before, because together, the 9 local authorities, and to a much lesser extent, the NHS, we created the CHAMPS network. We funded the CHAMPS network. We fund pieces of developmental work that they do. And the Health and Social Care Partnership has got something like 19 transformational change programs currently running, and we should be looking at those. We should be looking at, are those transformational change programs, all of which who have some funding, doing the things that match our highest priorities? Yeah, so the biggest change will come for us changing what we do with our core funding, but that takes time. Small change and seeds of change and creating transformation, we've set money aside for that. So let's spend some time considering the recommendations that come from this report and make sure that the transformational programs we invest in are the right ones so that we can seed more change more quickly.
Thank you, Graham. I shall now go, I think, Michael, do you want to come in on that one?
Yeah, when I chaired the WHO Commission on Social Determinants of Health, when we produced our final report, and I said, we have the knowledge of what we need to do to create greater health equity. We actually have the money. It's maldistributed. The question is, do we have the will? And soon after that, I spent a year as president of the British Medical Association. And because I didn't know anything about the BMA till I became president of it, I didn't know that right in the front, they talk about head, heart, and hands. I thought, hello, that's pretty much what I was saying. The head, the knowledge, I put in the other direction, hands are the technical doing it, and the heart is the commitment and the will. So what we're talking about in Cheshire and Merseyside is not letting national government off the hook, not by any means. The funding really matters. If you take more than £400 per person away and give £33 back, that makes everything much harder. So no question. So we shouldn't be letting national government off the hook, should be standing up. So the money really matters. But the knowledge and the heart, the will, and as we've heard already several times this afternoon, the heart has to come from the community as well as from outside. It takes committed people, committed professionals, but it's got to come from the community as well. So get those three together. Get the heart, get the head, the knowledge, and the will. We can make a huge difference, but we need them all.
Thank you. Ian Moncur.
Thank you, Louise. I just following from Michael and Graham, I think that this is the challenge, isn't it? Because this is the the really difficult bit of shifting from illness treatment to health and well-being. And I think that's not going to happen quickly. I think some of the discussions about structures and processes are important, but it's about developing those relationships, developing that trust to actually enact that. Both I would suggest it's important at a regional level, but it's even much more important at a local level, that people develop those relationships and that trust to actually make this change, and understand that's where the real change is going to happen. Is the more local level that we get to, that's where real change is going to happen. If that's supported at local authority type of level, at regional level, then that's where the change will happen. And I obviously entirely agree with Michael's point. You know, the level of resources that have been removed out of the system hugely hinder that, but we've got to be up for it to get in there and make things work as best we can with the resources available.
Thank you. Ian Ashworth.
Thanks. So from a public health perspective, we're always used to having small slices of the pie and making sure it goes a fair long way. So and that's right, because you know it's resources that we're stewards of, and we have to make sure that we're effective use of them. We can always obviously do more, and I think the best thing out of this is showing it's not just the NHS, it's not just the local council, but the communities and the economy all have a role to play in all of this, making sure that really good standards of work are in place and pay well as well as that. But we do need to, I'll just make a couple of notes of some key things that we do locally around what are called care communities, or others will have similar ones where smaller communities have got different priorities compared to, let's say, Winsford compared to Ellesmere Port and the patch that I cover. And it's important that we listen to them and adapt our what their needs are as well. So understanding the data, the population health data behind that is really crucial, which we're putting into place. So thank you.
Thanks, Ian. So Michael, I've got a question specifically for you here. Is there somewhere that has successfully reversed inequalities? And if so, how did they do it?
Well, let's start at home. Benjamin Seaborn Roundtree's work in York in 1900 showed that infant mortality in the poorest area of York was around 250 per 1,000 live births. And in the servant keeping class, so-called, of York, it was around 100 per 1,000 live births. The difference was 150 per 1,000 live births. Now, the best off group, it's about 2, not 100, 2 per 1,000 live births. And in the worst off group, it's about 5.5. The difference has gone down from 150 to 3.5. My goodness. Look at the progress we made. That's enormous. And notice I'm talking about absolute differences. The relative difference is, 3 now, and it was 2.5 100 years ago. So it's the absolute difference really made a difference. And in fact, the fact that it's widening again now is concerning, but we're not back at 1900 York. It's widening, it's going up in the poorest group, which is extremely worrying and really shouldn't happen. It's an indicator of something bad, but put it in the perspective. So now let's look at adult mortality and life expectancy. What's been documented is if you look at the life expectancy of the poorest 20% of local authorities in the country and compare it with the rest, in the 2000s, that gap narrowed. Now, if you were a New Labour devotee, you'd say New Labour did it. You notice that's not where I started. It did narrow during the New Labour period. Whether the government was responsible, we can argue about, but the fact is it narrowed. From around 2012 on, the gap increased again. So if you wanted to make party political points, you could say, yeah, we've had experience of narrowing the gap. We did it in the 2000s, and then we did the reverse experiment after 2010 and showed we could increase the gap. Well done, chaps. You've done the experiment. You reversed national policy and you increased the gap. So if we start close to home, we show that it is possible to change it. If I look at some of our global work, take Brazil, stunting in the first year of life, dramatic social gradient of failure to grow in the first year of life. It may have been related to the conditional cash transfer program in Brazil, giving poor people money, other programs, and they more or less flattened the social gradient in a fairly quick time. And I can point to other countries that have done that. So yeah, we don't have to accept the magnitude of health inequalities we see as a given. It's possible to change it.
Thank you. Thank you. That was an excellent answer, and I know you could probably talk about that all afternoon, Michael. And it's fascinating to look. And I think, wouldn't it be great in 5 no, it's okay. In 5 years' time, if we could come back, all of us together, and say that we made a difference, and then actually this is an example here of in Cheshire and Merseyside, how we've flattened the gradient. Would be absolutely fantastic. So I've got some slightly different questions. There's one about higher education. So higher education has research capability. How can we fund a community of practice to support grassroots organisations to evaluate the social value of what they're doing? So in other words, how are we going to measure? And I know, Michael, your team's been involved, but what role has higher education got and their expertise in actually helping grassroots organisations to evaluate the work that they're doing in terms of social value? Michael, I'll start with you, and then I'll bring it to the rest of you for some ideas at a local level.
I had an important lesson from a New Zealand Maori marae that outside Wellington, and they said to me, we get people from the universities come to us all the time, and we say to them, if you're only interested in using us as experimental subjects, it's been nice to talk to you, but goodbye. That we have no interest in being your subjects for your research. If you want to work with us, then we welcome you as partners. And I think in an earlier time of my academic life, I might have been like those researchers from New Zealand University who went into a Maori community and say, we want to study you lot and see what we can find out. I'd like to think that late in life I learned some lessons, and that what they taught me was the importance of partnership, not just in taking action, but in trying to understand. And it's that trying to understand and assessing the value of the action. It's a different way of doing research. The other way is important too. So I'm not knocking what I did for all those years, but it's a different way of doing research. And it's related, it's partnership, it's related to action, it's learning by experience. And we need to apply those insights.
Thank you. Ian Ashworth.
Thank you. So we have some fantastic higher education establishments across the whole Cheshire and Merseyside, from the University of Chester, close to where I work, to all the Liverpool universities as well. And actually, already together, some of them are represented and sit on our Marmot Community Board. And so it may be a question we go back to them directly on, about funding opportunities, research grants, opportunities we can work together on some of that. So that's something I can take away with. There are other examples as well, though, where I'm just thinking of a local one where we're growing our own social care workers, our Think Ahead programme at the University of Chester and the council, and to have a much needed health and care workforce around that. So there's another opportunity to keep, because we want people to stay in our area as well as when they educate as well, don't we? So I can take that away.
Good. So that's our first action of the day, isn't it, actually, Ian? That's brilliant. Well done. Because actually all of us need to take actions away from today. So I'm going to ask Graham and the other Ian, what is the one action you're going to take away from today? Because that's the challenge to every single person, all 500 of you on the call. What is that action you're going to take away from today? So Ian, Moncur, not the Ashworth.
Thanks ever so much, Louise, for putting me on the spot like that. I think the one action I'm going to take away would actually be a bit of a challenge to myself in terms of the points that have been raised here and how I can relate them, particularly as in Sefton Chair of the Health and Wellbeing Board, into direct sort of direct actions and direct reports of actually translating them into actions will be what I'm going to do.
Great stuff, Graham.
So I'll say two things. I am going to make sure that the Marmot recommendations are incorporated into the Integrated Care Board's 5-year strategy. Now, I'm going to get the word wrong here, but Michael used in his presentation earlier something that I'm going to call sentinel measures, but Michael used a slightly different word to that. I am going to make sure that in our corporate scorecard, how we tell ourselves whether or not we are doing a good job, that we incorporate those sentinel measures into all of our, kind of public assessment of what we do and whether or not we say we're doing a good job. And that in itself will keep people focused and making sure that we are starting to make a down payment on delivering some of the changes, which in some cases take many years.
So thank you very much for all of those comments. We are going to have to draw the session to a close. There's lots and lots of questions and comments in the chat. We're going to keep the chat open for longer than the event. So if you want to add anything to it, please do. And all of it is going to be collated. And I know Sir Michael's team are really interested in this. So we're going to collate it and make sure that we capture all of this as a summary of the event this afternoon. I think the main thing that has come out of this for me today is we can't just tinker around the edges. We are going to have to be really brave, and we're going to have to be bold. And we're going to have to work together on this. Not one of us is strong enough or big enough to be able to do it on our own. So that collective ambition is going to be so important as we go forward. And I would like everyone here to think about, right, what am I going to do to make Cheshire and Merseyside altogether fairer? How are you going to take that back to your organisations to start making the change that's required? So in terms of what happens next, the Directors of Public Health and the Integrated Care System Population Health Board will continue to work on the recommendations and look forward to working with you all to help make sure this happens. But work will, as Ian Moncur has said, work will be going on at a local borough level. So we're going to have our overarching report, but to really make this happen, it has to come down to our places to make it happen. And now that we have the strategy, which will go live at 12 midnight tonight, I think, after Newsnight has shared it and aired their programme, it's up to us to deliver it across Cheshire and Merseyside. So no pressure there, but that's your challenge. The live recording of this will also be on the Champs website later on. And I think all of the health and wellbeing boards and the health and wellbeing strategies are currently in the process, those place plans are being updated and refreshed to actually reflect the needs of those local communities. And, you know, in Cheshire Merseyside, we're really lucky. We've got so many assets that we can build on. We've got a rich natural landscape. We've got beautiful green spaces, rivers, coastlines, and we've got lovely urban parks as well as our rural landscapes. So we've got a good baseline in terms of where we need to go. And we do have that opportunity now to actually make that change within the system to improve people's lives. Somebody put a chat in, is it about living longer lives? And absolutely not. It's about living happy, healthy, fulfilled lives. And I think that's really, really important, and living those happy, healthy and fulfilled lives for longer. So there will be a Mentimeter that is sent out to you. I think Ryan's going to share on his screen and put a code in the chat. So you need to think of 3 words that describes how they're feeling after the session today. And finally, I'd just like to thank everybody for giving up their afternoon, thinking about the challenges and the opportunities that lie ahead. And thank you so much to Sir Michael and his team for helping us to get to this position, to our directors of public health, the integrated care system, local government, community and voluntary sector, and our wonderful residents. And we will get this done, and I can't wait to start seeing the results over the years to come. So without that, and I think I've covered everything, I'll get shouted at if I haven't. But without that, I'd like to wish you all a good afternoon, and don't forget to watch Newsnight tonight. And goodbye, and stay safe and take care. Bye bye.